This is the fall 2025 research update. I'm recording this after the fact because I forgot to press record. We're really excited about this program, which stemmed from conversations at the 2023 FDMAS Alliance Community Conference. Please enjoy.
23. And all of this gives us strong confidence that important advances in our understanding of fibrous dysplasia will continue to emerge in the near future. So, going to the specific of the review, the aim of the review was to detail the critical basics and translational findings that have emerged since the first description of the disease, and also to highlight the key concepts and the tools, but also and especially the gaps for future research in the field. And this is very quickly, I'll show you the slide, the structure of the review that we have used. So we have a background and where we introduce the disease. And then we go into the specific sections like the FD histopathological features, the basic research on human FD samples with two subsections on the ex vivo cell culture of primary human cells and the genetic and proteomic analysis of primary human samples. Then there is a big part on vivo models, and where we summarize the non-transgenic and the transgenic mouse models. Then there is a novel part on pain from a basic and translational point of view, and then a basic and translational point of view about the therapeutics that are used to treat fibrous dysplasia, and then we'll have the conclusions and future direction. But in this presentation, I will try to summarize the key points of the review paper because it is impossible to go through all the papers that we have included in this review article. And of course, with a personal selection of some topics for the sake of time. So let's start from the basics. What's FDMAS? So it is a rare genetic conditions and happens after conception, and it is not inherited from parents because it is a somatic mosaicism. So it results in this mosaic pattern, meaning that some cells are affected and others are not. And it can affect bone structures, but also involve multiple organs. And what I find really interesting is the first description of FDMAS that was published in 1937 by Albright and his co-authors. In the same year, McCune described another case and other similar cases. So they realized that other similar cases had already been reported in the literature, outlining a syndrome characterized by bone lesions which have a marked tendency to be unilateral and which show osteitis fibrosa on histological examination. Then brown, non-elevated pigmented areas of the skin, which tend to be on the same side of the bone lesion. And then third, an endocrine dysfunction, which in females is associated with precocious puberty. So as you can see, already in 1937, there was a very complete and full description of the disease. And most aspects described in this paper are still under investigation today. And what I find really interesting is the drawings of the skeletons showing the FD involvement in the skeleton of the 5 cases described in this paper. So what causes FDMAS? So the genetic cause of fibrous dysplasia, McCune-Albright syndrome, is found in the GNAS gene. The mutation in the GNAS gene causes cells to produce too much of a signaling molecule called cyclic AMP. Usually normal cells, the signals leading to the cyclic AMP productions can turn on and off appropriately. And what happens in FDMAS cells is that the signal stays on constantly, causing problems. And going into the specific, and this is a scheme that we have included in the review article. So the GNAS encodes for the alpha subunit of the stimulatory G protein that we call G alpha S. And this is a representation of the G alpha S pathway at physiological conditions, I want to highlight that this pathway is very important for many cells in our body, including bone, but also endocrine organs. So G-alpha-S is this subunit in purple here that it is part of a heterotrimer composed of alpha, beta, and gamma subunits. So these are connected to this receptor that we call GPCR, that stands for G protein coupled receptors. When a ligand arrives and binds to the receptor, the G-alpha S, that is normally binding the GDP, exchange the GDP with GTP, dissociates from the beta and gamma, and goes to activate the adenylyl cyclase. This leads to the production of cyclic KMP and activation of the pKa, and then this causes the phosphorylation of downstream effectors and gene expression that are related to this pathway. What is also important here is that whenever this signals is on, so the G-alpha-S has the so-called GTPase activity, meaning that it is able to turn off the system, exchanging the GTP with GDP, going to the resting position. So this is what happens normally. The mutations that cause fibrous dysplasia impair the GTPase activity, meaning that the signals stays on and cannot be turned off. This leads to constitutive activation of adenylyl cyclase to produce cyclic KMP that accumulates in the cells, and this leads to overactivation of pKa and then FD-related gene expression. In the review, we also wanted, we have added one recent finding about the R201C mutation. So the authors describe that whenever we have the R201C mutation, this can directly activate the GDP-bound subunit and directly stimulate the adenylyl cyclase, further increasing the accumulation of cyclic KMP. So all the problems causing fibrous dysplasia depends on this pathway, most of it. But how it affects bone? So what happens in bone is that normal bone is replaced by fibro-osseous tissue, that is a scar-like tissue. New bone forms, but it's weaker and poorly organized, and the bone doesn't mineralize properly, making it fragile and leading to pain, deformity, and fractures. And if we go into the bone lesions and see what are the features, the histopathological features of fibrous dysplasia. So on the left, I reported the pictures from the paper of Albright in 1937. They were in black and white and grays. And on the right, the sections that we have reported in the review article. I have to say that the features are the same, but we are a little bit, we have new tools that allow us to image the histopathological features a little bit better than in 1937. I have to say more colorful pictures can come from the new tools we have today. And here in these pictures, it is highlighted the bone that is in red. And as you can see here, the arrows are pointing to this collagen bundles that are called Sharpie's fibers that normally should be parallel to the bone structures, but in fibrous dysplasia are perpendicularly and are connecting the bone trabeculate to the fibrous tissue. In the picture from C to F, there is a special staining to highlight the osteoclast that appear in red in these pictures, and this is a major feature of fibrous dysplasia, the intense osteoclastogenesis that causes bone resorption. So an important part of the review focuses on the cultures of FD cells because the earliest foundational work on FD was done on primary cells, and the cells isolated from FD donors have been helpful for understanding the basic mechanism of abnormal osteogenesis and release of signaling molecules. Different approaches were used during the years, so people have directly isolated bone marrow stromal cells, so the cells that you can isolate from bone directly from FD bone biopsies, or the cells could have also been isolated from healthy donors and then genetically manipulated to express the FD causative mutation. Or this is more recent, people are generating induced pluripotent stem cells from cells that can be of other sources rather than bone. And this is a very useful technology to better study the disease. Just to give you some example, this is one of the first evidence on how primary cells were used to understand the pathogenetic mechanisms in FD. So we today know that skeletal stem cell, that FD is a skeletal stem cell disease thanks to foundational studies like this. In this study, researchers isolated the bone marrow stromal cells from the bone biopsies of healthy donor patients and FD patients and transplanted the cells into the mice, into the back of the mice to generate some human ossicles in mice. While the ossicles from healthy cells contain normal bone and bone marrow, the ossicles deriving from FD cells contain fibrous tissue. And this was a very important finding because it demonstrated that information to generate the disease were contained in the skeletal stem cell population. Another examples of what we can do with primary cells isolated from bone specimens is to understand their expression profile. And this was done, for example, in these two papers where gene associated to bone formation, angiogenesis, osteoclastogenesis, for example, rank ligand over expression was revealed by these studies. So the studies can be really, really important to understand what FD cells are secreting or expressing differently than normal cells. And I would like also to highlight this paper from Kelly Wentworth, Fernando Fierro, and Edward Xiao group that unfortunately came out after our review. And so we could not include this paper in the review. But the authors performed for the first time a single-cell RNA sequencing analysis of cells isolated from FD human biopsies, and they show the atlas of the cell populating the FD lesions. So among the many results the paper shows that there is a fibroblast composition in FD bone with a FD-specific osteoblastic cluster. So I really suggest the reading because it's a really nice paper. Another section of the review is dedicated to the mouse models of FD. So why the mice matter? Mouse model of FD have been generated to better understand the disease and to better understand the pathogenetic mechanisms, to study how the disease develops over time, to identify new potential treatments, and very important, to test treatments safely before human trials. And this is a list of the mouse models of FD that have been generated during the years. Here we report how they have been generated, the skeletal phenotype resembling FD, and other informations. I know that this can be very tricky to follow for some of you, especially the model names can be difficult, but I will try to explain to you this terminology and the names. So before the mutation that here is underlined in red, and you know very well that GMAS expressed the mutation that has been expressed in these mice. Before this GMAS, before the mutation, there is here outlined in red a promoter. This promoter serves as driver of the mutation. So today, you can use different promoter based on which cells or differentiation stage you want to express the mutation. This is incredibly helpful to understand the effects of FD mutation in different cell population because the mouse genetics allows us to specifically put the mutation under one of these cell population to understand what are the skeletal phenotypes, skeletal effects of the mutation. So at the end of all the studies about the cellular studies and the mouse model studies, we added this schematic representation of the hypothetical G-alpha-S mutated skeletal stem cell function and differentiation capacity. So the skeletal stem cells are thought to be the source of the osteogenic stroma that we call here FD cells, and these cells accumulate in the bone marrow in FD affected skeletal segments. Mutated skeletal stem cells are able to
아까
give
그런
rise,
식으로 행동을 했구나.
are able to give rise to osteoblasts, but are defective in generating bone marrow adipocytes that are normally present in the bone marrow. So the FD cells composing the fibrous tissue may also derive from either differentiated osteoblast or from the expansion of resident bone marrow fibroblasts. That's why we put the dotted arrows, because this mechanism is still not understood very well. But it is also confirmed by the paper that I showed you by Fernando Fierro, Kelly Wentworth, and Edward Xiao. But most importantly, the skeletal stem cells, the mutated skeletal stem cells, produce rank ligand that stimulate osteoclast, that through the resorption and through coupling factors that are probably secreted, and also here we still don't know very well, allow the expansion of this bone marrow fibroblast population. So when we talk about FD pathogenesis, we often refer solely to the mechanisms by which FD lesions are generated. But there are other important issues which we don't know the mechanisms, and one of these is pain. So we decided to include a section on pain in FDMAS in our review because it is a very important clinical issue, and we think that the basic and translational research can help in understanding the pathogenetic mechanisms and also in treating pain. So what we know about pain from the clinics? We know that pain is a common and can significantly impact the quality of life of FD patients. And pain severity does not correlate with the disease burden, and this is a very difficult thing to understand. And we also know that the pain in FD patients may have both nociceptive and neuropathic components. So the damage is definitely at the level of the tissue, and this can activate the nociceptors in bone, but also can come from a damage directly to nerves, for example, like nerve compression. The current research focus is to understand the pain mechanism to develop better treatments. And so our bone is innervated by these A delta and C fibers. These are sensory fibers. This is a nociceptive mechanisms, how the nociceptive signals reach the brain. So these fibers can be activated in bone by injury, mechanical distortion, inflammatory signals, or pH. And the nociceptive signals travels to first to the nerves into the spinal cord, and then the brain receives the signals and generates the appropriate response. There are different mechanisms underlying bone pain. One of these is the acute activation of mechano and chemosensitiveness nociceptors, for example, with inflammatory signals, but also the sensitization of peripheral nociceptors is another mechanism, or the ectopic sensory nerve sprouting, or we can have transcriptional changes in sensory neurons and also the central sensitization. So why we added this part of pain in the review? Because the 2025 was a very important year for pain in fibrous dysplasia, because the first two studies on pain from a basic and translational point of view came out in the same journal and came out in the same month. So this was really incredibly to see. One is from our group and one from the group of Anne-Marie Hegard. And the two papers are both really important because they highlight two different aspects of pain in fibrous dysplasia. So the first, it rules out the possibility of a pathological growth of nerves into fibrous tissue lesions. So what we demonstrated is that we don't see a pathological nerve sprouting within the FD lesions. And this is important because it rules out one of the mechanisms underlying bone pain in some other conditions. And the other papers identify some nociceptive mechanisms by which the pain can be initiated in fibrous dysplasia. And for instance, they found out that bone marrow stromal cells from fibrous dysplasia express inflammatory signals and also some neurotrophins that can activate the nociceptors in bone. So I move now to the last part of the review and also of my presentation, that is the current treatment in fibrous dysplasia. We know that, and I showed you already this picture, so osteoclast and bone resorption are major morbidity factor in fibrous dysplasia, and they are also therapeutic target in FD, and especially rank ligand after it was demonstrated that it is involved in the pathophysiology of fibrous dysplasia. And indeed, the two available treatments for fibrous dysplasia are bisphosphonates and denosumab, that is a rank ligand inhibitor. So during the years, it has been demonstrated that bisphosphonates are not really effective in fibrous dysplasia. They can be used for treating pain in some patients, but they are not effective on the disease burden. This has been demonstrated in humans with this randomized double-blind placebo-controlled trial with alendronate, but it has been demonstrated also in mice treated with zoledronic acid. And on the contrary, we know that rank ligand inhibition with the use of denosumab is an effective strategy in fibrous dysplasia. And this was demonstrated in mice in multiple mouse models. And also here I report a work from Julia Charles' lab that we couldn't include in our review for the same reason, because it came out after we published the review. So that rank ligand is effective strategy in FD has been demonstrated in different mouse models, but it has been demonstrated also in humans by the group of Dr. Boyce. And why basic research is important? Because it has helped us to understand why bisphosphonates are less effective than denosumab, or at least why they may be less effective than denosumab. So we know that bisphosphonates can reduce the number of osteoclasts and drastically reduce also the bone resorption, but we know for a fact that cannot halt the disease progression, so we still have fibrous dysplasia. Moreover, we have demonstrated that bisphosphonate treatment can lead to the formation of giant osteoclasts, and this is a picture from a human biopsy of FD patients treated with bisphosphonates. We don't know very well the function of this giant osteoclast, but we think that they can still orchestrate the tissue pathology, and that's why bisphosphonates are not effective in FD. On the contrary, denosumab is able to deplete osteoclast population and drastically reduce bone resorption, and we know it is effective in preventing the disease appearance in mice and halting the progression in mice and humans. So also other treatments, we have hormone treatments for managing endocrine problems in McCune-Albright syndrome, and also the surgery for specific complications like fractures and deformities. So the promising research direction, what's being studied right now? So the Wnt beta-catenin pathway. So some research shows that this pathway is overactive in FD, and blocking it may help in also reduce the disease. Then the FGF23 antibodies. So this therapeutic strategy aimed to treat low phosphate levels and osteomalacia in fibrous dysplasia. And there is an ongoing clinical trial, and the principal investigator is Dr. Boyce. But also the pKa inhibition and the cyclic AMP reducers. These drugs could lower the excess of the cyclic AMP signalings. And about this, again, another paper we couldn't include. So just to show you that there is an intense research going on fibrous dysplasia. This is a paper from Dr. Zhao showing that the protein kinase A can be a therapeutic target in fibrous dysplasia. This has been demonstrated to be effective in a mouse model. And then also some pain-specific treatments we are studying. We are trying to target inflammations and neurotrophins expressed by FD lesions. So in conclusion, the key takeaways here, we definitely understand the disease much better than before. So we know which gene is involved and many pathological mechanisms in affected cells. Multiple treatments are available now. While not curing the disease, they can help managing the symptoms and slow the progression of the disease. Clinical trials new treatments are being developed, and the clinical trials are testing these promising new approaches. But what is most important, the research is ongoing, and it is active, and scientists worldwide are working to understand better the disease and develop new therapeutic solutions. And I want to conclude with this picture that was taken in our last meeting at the FDMAS Consortium in Madrid in 2 months ago, no, last month. And again, research advances when patients, family, and scientists work together, and I really believe in this. So thank you very much for your attention, and I'm really happy to answer any questions you may have now or later. Thank you.
Thank you so much, Biagio. That was a really wonderful overview of a very complex topic. So, everyone, please do feel free to put your questions into the chat. I'll go ahead and start us off. Biagio, you did such a really great job of kind of walking us through what causes fibrous dysplasia, how it starts with the cyclic AMP and then leads to these complex bone changes. I think one of the problems a lot of us studying FD have tried to deal with is the fact that this pathway that's turned on is so important in so many different cells and so many basic things the body is doing. Do you have any comment on how that might impact the way we interpret some of these studies and some of these targets we're going after?
Yeah, so definitely. So this is, as I said, is a very ubiquitous pathway and is so important for many organs. I think this is the fact that it is so important for many organs and many cell types is really hampering our, way to at least try to target some of the molecules within this pathway. And what I mean is that, of course, whenever we try to inhibit something in the GS-alpha pathway, we really need to be cautious into, and try to inhibit only the bone specific pathway. Because and so I also the pKa inhibitors that the paper from Dr. Zhao showed, this is really promising, but we really need to target the bone only. So this is probably the most difficult thing in this field, to reach the bone only and be specific there. And of course, there are a lot of molecules that are that can be upregulated by this pathway. So with the research, we are probably focusing only on rank ligand, for instance, but I'm quite sure there are many, many molecules that can be targeted.
Yeah, no, I totally agree. And what I might add to that too is it's also complicated that the disease is mosaic. So some treatments might want to target just to the bone, but other t treatments that are trying to target even closer to that cyclic AMP, we might need to try to target only to cells that have the mutation, which is even harder and an even more specific subtype of cells. So this is a really tricky disease to treat.
It is, and also as I see here, Dr. Fierro. So I was fascinated by the fact that in FD lesions you can find, and we know this, you can find wild-type cells also. But I was fascinated by the fact that you cannot really. So within the FD lesions, within the fibrous tissue, you can have the mutated cells, but you can have also wild-type cells that are contributing to the pathology, and so maybe targeting only mutated cells can be the way, but it seems from the paper from Dr. Fierro and Xiao that also the wild-type cells are doing something similar to the mutated cells. It seems that if they go together also in a pathological way, so that is really fascinating and tricky at the same time.
Yeah, like I think what you're saying is that the problem isn't just turning off the problems from the mutation, but that the cells are talking to each other in an abnormal way. And maybe we need to think about interrupting the way the cells are talking to each other as a possible treatment. And that might
Exactly.
be. Mhm.
Yes, exactly. So it seems like wild-type cells are behaving like if they were mutated cells.
And I'll just say wild type means the cells that don't have the mutation. So.
Right. Sorry.
Mhm.
Yes, exactly. Exactly. So normal cells and mutated cells are
Mhm.
doing the job together. Um,
Yeah, I always say it like the cells that have the mutation are sort of shouting at the cells that don't have the mutation. And at the end of the day, it's sort of like when you have a kid in a classroom that's acting up and all the other kids are acting up too. If you just walk into the classroom, you can't tell who the instigator was very easily.
I like that. Yes, exactly. I like the metaphor.
Great. Well, again, I guess while we're waiting to see if anyone else, Tova, did you have a question?
Well, no, I was just going to invite anybody who, I mean, I always have questions, but would like to invite anybody who does have questions. If it's easier to put it in the chat for you, you're welcome to do that. And I do see many of the authors who are on some of those papers that hadn't come out until after the review article. If anybody wants to comment, I think I welcome that discussion.
So, Biagio, I was wondering too, I really enjoyed your discussion of the different models. I think it shows like what these are the key tools we have to use to try to find better treatments. What do you think is one of the biggest limitations of the models we have right now? Like what do we need to fix to make the models better?
Yeah, so that's a great question. So I think all the models we have are great, and some of them really can tell us part of the disease. So some of them are telling us how the disease developed, for example, and because they basically develop spontaneously the disease. Some of them can be useful for testing some treatments. For instance, the two mouse models used for pain, they are very different mouse models. So the one that we used develops the disease spontaneously during time. And so you can definitely follow, the disease progression and also the pain progression during time. The other model was really useful to understand acutely what is causing the pain and the disease. So for that reason, the two models were, I think, were absolutely great to answer specific questions. What is still missing is probably a model that, first of all, reproduce fully other aspects, for example, the endocrine dysfunction. So as you can see in the table in the review paper, some models can also have some phenotypes in the endocrine organs, but these are definitely this is not happening in 100% of the mice. These are rare manifestations also in mice. All the mice reproduce a skeletal phenotype, but not a full McCune-Albright syndrome phenotype. And another aspect of the mice is that you cannot really create a somatic mosaicism because we cannot generate every time mice with somatic mosaicism. So we need to breed the mice to have, colonies. And so the mutation must be inherited from parents. And this is something that is really interesting because in mice, the mutation can be inherited. And we know this from these mouse models.
Yeah, I agree. I think models are such a complex thing. They're all very flawed at the end of the day. We say these mice have FD, but they don't have FD. A mouse can't have FD. It's something only a human has.
Exactly.
So they all have some type of different version of FD. Oh, I see we have a question that says, "Thank you, Biagio, for this talk. Do the mutant fibroblasts produce rankle in FD?"
Yes, the mutant fibroblast, it has been demonstrated in humans and also in mice. The mutant fibroblast express rank ligand in FD. I don't remember if now the wild type fibroblasts in the FD lesions express rank ligand in FD, but I expect this to be true also. So yes, rank ligand is expressed by fibroblast in FD lesions.
Yeah, just kind of alluding to what we were saying earlier, like Biagio shared, it seems to be one of those things we think the mutant cells might be shouting at the normal cells. That and possibly that's why they're all making it.
I have a question. Often people write to the Alliance asking about gene editing and seeing exciting articles about gene editing or precision medicine where they're using AI to test many, many different theories and pathways. And what you were describing earlier about the mosaic nature and how it can affect some cells and not others, is that the reason that gene editing, while exciting, is still sort of a long shot away from where we are now? Or how can you help us understand where the FDMAS community would sit with that?
So yes, so first of all, the somatic mosaicism is making everything more complex. But I have to say, um, the problem with gene therapy during the years, and so there is a big problem with gene therapy into the bone. Okay, this is not the only disease where we cannot perform gene therapy. Targeting the bone is always very difficult because we don't have a way to reach the bone cells to transfer, let's say, the correct version of the gene.
Mm-hmm.
So that's a major problem. So I would say, yeah, that is the biggest problem. But definitely, I think that if definitely we have new tools today. Okay, so I was saying these things thinking to what has been, the last 20 years in gene therapy. But today we have new tools and we can definitely try and do some research. And for this research, mouse models are super important because you can really test gene editing in mice before going, of course, into humans and into clinical trials. So for this, absolutely, I think this is an important path for FD research in the future.
Yeah, I think that's a nice example of how, different models tell us different things. You can use cells to find what pathways might be interesting, but you can't really test the safety or how well a drug is going to work in a cell. You need a mouse model, and that's why it's nice that we have multiple types of mouse models. It's been a huge advance over the amount of time I've been in this field. We have another question. Does burosumab target the FGF23 antibodies?
So the burosumab is an FGF23 antibodies, is a monoclonal antibody for FGF23, and it's been using and probably Dr. Boyce can say something more about this because she's leading a clinical trial with burosumab in fibrous dysplasia.
Yeah, and thank you for bringing that trial up. It actually recently finished, and the results are available on what's called a preprint server. So that's where scientists will submit their paper right after they write it, but it hasn't undergone what's called peer review by other scientists yet. So you can access all of the results there on a server called medRxiv. And then hopefully the full paper will be out very soon. It's being reviewed by the journal now. It worked very, very well. I'm very excited about burosumab for patients who have low phosphate with fibrous dysplasia. One disadvantage of burosumab, though, is it really will probably only work if you have low phosphate. Most patients with very severe FD that impacts, I would say, half their skeleton or more will have low phosphate, but it won't be as helpful for the patients that have a smaller amount of FD. And I see we have another question. Any thoughts about ablation of bone marrow and transplanting with normal bone marrow? Will this rescue the skeletal phenotype?
So this is a fantastic question. I mean, thank you very much. So we have thought about this strategy many times in lab, and so let me so in theory, this would be a great strategy. The problem is that the mutation here, so the cells that are responsible for the disease in fibrodysplasia are the osteogenic cells, so the cells that make bone. Whenever we do the ablation of the bone marrow, we cannot really, we ablate bone marrow cells and probably also some osteoblasts. The problem is that we don't know how to transplant the new osteoblast, the healthy osteoblast. So we know how to transplant healthy bone marrow cells, let's say from the hematopoietic system. And this is used, for example, this is a strategy used in multiple myeloma where you have problems in the and let's say in the hematopoietic lineage, and also in some leukemias. But this cannot be if we think that osteoclasts, let's say, are also some very important for the disease, then this could be also a strategy. So the problem again is we still don't know, but this is not only in fibrous dysplasia, but in general in the bone field, we don't know how to transplant healthy osteogenic cells, meaning osteoblasts and or osteoprogenitors or skeletal stem cells. We cannot really inject skeletal stem cells in the blood because they don't know how to reach the bone. So, but this is a very important topic. This is a super important question. Thank you very much.
Great. And then we also have a question. Does stem cell research have the same problem as gene editing? Which I think is similar to what you just answered about some of those limitations. Yeah.
Yes, absolutely. We have a disease that involves also the osteogenic lineage. Okay, so the cells that make the bone, not only the lineage that resorb the bone. The osteoclasts, that are the cells that resorb bone, comes from the hematopoietic lineage. And in theory, if we had disease that was solely caused by osteoclasts, this could be an effective strategy. But unfortunately, it is not.
Yeah. And also, even if it were effective, there's a pretty lot of risks with something like a bone marrow transplant. There are some diseases, bone diseases, where it can be effective. I'm thinking of a disease called osteopetrosis, which is a disease of osteoclasts. And it's a really hard decision whether or not to do the transplant in those patients because the treatment can be fatal. So you have to weigh the risks and benefits. But I think it's a really exciting way to think about it. And it is certainly possible that some way in the future we'll be able to capitalize on that strategy in like a more targeted way.
Yeah, yeah. We need to understand how to make the stem cells, to go into the bone. That's the
Mhm,
point.
mhm. Yeah, hopefully research in other areas can definitely help us understand better ways to treat fibrous dysplasia too. So important things to watch.
I have, I think, at least two other questions. Circling back to the mouse models, we in our research updates often get to hear about exciting results from a mouse model. But I understand that the results that we see in one mouse model, because it's slightly different and not exactly FD, doesn't necessarily translate to how it might affect
Mhm.
people. Are there standards for checking out those pathways in different mice models, or a reason to go with one model versus another beyond just access?
So one limit is the access of the mice. Of course, so I mean, whenever we put also the mice on publicly available, databases or companies where you can really buy the mice are really expensive. Okay, so the different groups around the world have mouse models, and usually you test the mouse models you have. Okay,
Right.
but anyway, the one example, and was one very, I think, successful example, was with the rank ligand inhibition. So nowadays we have tried to inhibit rank ligand in all the mouse models, and we have done it also in humans, and we know that is effective. So uh, my what I was thinking is that um, if a strategy if a strategy is effective is really effective in one mouse model, then it is really effective in one mouse model, then can be effective in other mouse models. That is the strategy we need to choose, we need to pick. So um, we need to think about the strategy first, and really try to focus on target on molecules that can be targeted, can be really targeted, instead of trying to many molecules we will never be able to target in humans, for example.
I see another question in here.
Oh, I see another question. How much confidence in general do we have in inhibiting rankle, considering all the results in mouse models and beyond?
I think this is a question for more for a clinician. I don't know if Alison wants to answer about this. I had to say, in mice it is really effective, and you can really prevent disease appearance by inhibiting rank ligand. If you inhibit rank ligand in mice, you don't get the disease. You don't have the disease at all. So rank ligand is really important for initiating the disease, first of all, but also in for the progression of the disease. How much confidence we have, probably Dr. Boyce can answer about
Yeah.
this.
I love this question because I think it really is a nice way of kind of illustrating some of that bridge we have to think about between the translational research and actually using something in the clinic. So inhibiting rankle will have very potent effects on fibrous dysplasia. It basically turns the fibrous dysplasia so if you already have fibrous dysplasia, if the lesion's already there, did not inhibiting rancor will stop it from growing, and and at high doses can even turn it into a different type of bone. It can make it like a very hard ossified bone that really looks nothing like fibrous dysplasia. That looks like something different and possibly easier to manage. But the problem is the side effects and how long we have to treat patients. And those are things that the mouse models are not always quite as helpful in. We can see beautiful results with making the fibrous dysplasia better in a mouse, but what the mouse can't replicate is going on lives out in the outside world after taking this drug for a really long time. If we give too much um, denosumab, we can make the bones very brittle. We can increase the risk of having fractures for a different reason. That's the last thing we'd want to do for a patient with fibrous dysplasia is give them a fracture. That's what we're trying to prevent. But with too much of the drug, we can cause those type of problems. So um, I think that's one of the nice things about research. The basic scientists can open up some possibilities. Then the translational researchers come in and study those possibilities further in different models. But once it gets to the clinic, it's a whole bunch of other possibilities that we have to investigate. So it's good to not to always have a kind of skeptical mind with any of these new treatments. They're really exciting, but there's a lot of things to think about that we won't even begin to address till it gets into humans.
Mhm. Yeah, just to follow up on this,
Mhm.
of course, the rebound after, denosumab discontinuation is the most important clinical issue with denosumab treatment. But I have to say, you can replicate the anti-rank ligand discontinuation rebound also in mice. Uh, However, you don't always get, and this is also rare in humans, you don't always get hypercalcemia in mice, but you can have some increase in calcium levels. You definitely have all the bone turnovers rise that you have after discontinuation with denosumab also in mice. But yeah, I agree with Alison that sometimes, of course, when you translate into the clinics, this can be a little bit more difficult than managing mice and a mouse room.
Yeah, and also we're thinking about too that we don't want to get too stuck in our thinking about fibrous dysplasia like it's one single disease. There's a lot of different ways we can come at treating it. So denosumab is could be a very helpful, really great therapy for some patients, but it's not for everybody. There's a huge need to understand pain and fibrous dysplasia, but I'll say there's a sizable proportion of people with FD that don't have pain that may not be as relevant for. So we want to make sure that we're coming at it from many different angles. Oh, one more question I see. How much does one quality mouse model cost that would help your research? That's
Nice,
the
nice
great
question. Yeah,
questions.
that's a great question because sometimes,
Very
this is
practical.
yeah, absolutely. So I'll make an example. So for the last work we did, we bought a mouse models to just to see some nerve fibers in our in our mice, and so a mouse can cost on, for example, at Jackson Laboratories from $2,000 to $4,000 one mouse because of travels and not only the mouse but also the travels because it's based in United States. So this is a major limit, of course, for basic research, but luckily we have really close community, and we often exchange the mouse models among us. So that's great because people can get the mice also not completely for free, but only paying for the shipment.
Great. I see we have another question. Is there a similar medication like denosumab? Like there are different types of bisphosphonates, maybe with less side effects.
I can just comment on this, and then I'll leave also the answer to Alison Boyce. So human studies with bisphosphonate. So the clinical trial was done with alendronate in humans. Alendronate is a type of bisphosphonates. But now today we have a third generation bisphosphonates like zoledronate, And to my knowledge, so I don't know if there are some trials ongoing with zoledronate and fibrous dysplasia. What we see in mice is that zoledronate can be effective in, let's say, early lesions. So in lesions that are at the beginning of the disease development. But definitely it is not effective like denosumab, but also this zoledronate that is very potent third generation bisphosphonate.
Yes, and for now, I'm not aware of any other types of denosumab, so like other medications that also inhibit anti rankle. It's certainly possible that some could be developed. Part of the problem we have with the rebound in denosumab is that it's an antibody. So it's a very small drug that leaves the system very quickly once you stop taking the medication, which is different than bisphosphonates that stay in the bone. You know, theoretically, if someone could develop a type of medication that inhibited rankle, but but was able to anchor to the bone and didn't leave the system so quickly, maybe we would not have problems with the rebound the same way. So there's certainly, I think that it's good to not get too locked into the thinking about denosumab being the only way to inhibit rankle. Right now, it's the only way we can do that practically, but that doesn't mean that there won't be other ways in the future.
Yeah, absolutely. And we have also tried, but there is a preprint on this. We have also tried to combine the rank ligand inhibition with zoledronate treatment in order to delay the discontinuation that is given by the anti-rank ligand discontinuation. And in mice, this seems to be effective for some time in delaying the disease rebound. But definitely, I know that people are already combining this in humans. So also here we will have some other studies in the future.
Yeah, it's just tricky because they have the same type of side effects,
Mhm.
denosumab and bisphosphonates. So you end up having to walk that fine line of maybe bisphosphonates can help us have less problems with denosumab, but then maybe we've now inhibited the osteoclast so much that we have other
Right.
types of side effects. So um,
It's really
so
wonderful to. Oh, is there?
okay, so from Cameron, am I correct in thinking the patent for denosumab just expired? How would that affect the generation of alternatives? I am not 100% sure, Cameron. I think you may be right, though, that it's very close to expiring. I know there's also a company that is that has developed another type of anti-rankle, which I think could potentially make it more affordable.
Mhm.
Um, yeah, I don't know. I don't know. I think that that it's true that when it comes to developing big drugs like denosumab is a drug that we borrowed from a much more common disease, so osteoporosis and also bone tumors. So we're very opportunistic in the rare bone space. Whenever a new medication comes out that we know we can easily give to our patients, we're really eager to see if there's any way of applying that to fibrous dysplasia. And that's something that is going to continue. And I think could potentially be a lot of promise in using that strategy in the future. There's a lot of new bone drugs coming out right now for different rare diseases, and we're always on the lookout to see if we can jump on the bandwagon.
So, I mean, my question was sort of to that end, where it's really wonderful to see it all pulled together like this. And thank you, Biagio, for covering so much material, and also to see how many more articles have come out even since. Why is there that proliferation of articles, or these new rare bone drugs? What can you help explain that for the patient community?
So your question is why there are so many articles on FD coming out?
Yeah, I think is this an accelerated, are we seeing the research accelerated, I guess?
So I will answer as a basic research. So as a basic researcher, so um, Rare diseases, and if you want, if you want to, an answer, a broader answer on other rare diseases. So I always think that rare diseases offer a unique opportunity to study not only the pathology but also the physiology. So thanks to fibrous dysplasia, we have understood so many things about bone physiology. Also, I just want to remind you that so the FGF23 stories when came out, it was when people published about FGF23 in fibrous dysplasia. That was also great to know, because then people discovered that was produced by osteoblast. And so um, rare diseases always offer, something, an opportunity to study the bone in this case, but also other organs if rare diseases affect other organs. So there is also a scientific interest in in studying rare diseases, and with this, all the the solutions that comes out are incredible in my opinion for both sides of the story.
Mhm.
I don't know if I answered your question,
Yeah.
but that was
Well,
um,
and then I'm actually borrowing this question from Sarah Healy, which she asked another research update, which is just, as the patient community, I love these research updates. I love bringing together the researchers and the community to understand where we are, and what is it that we, the community, can do to support these continued advances.
but I mean, the community is doing a lot in my opinion. So I've not seen other communities like the one in fibrous dysplasia, and I mean, I've seen other communities. So here you have always opportunity for for getting funded your research, opportunities to meet basically almost every year with webinars or in person, and all the support that the community is giving to the researchers in different ways. I think this is great. And I mean, also talking to patients sometimes can, really raise questions so that you never thought, you could address in your research. So that is super important for me. So that's my answer.
Thank you. Anyone else? Any any final words you want to add, Biagio or Allison, before?
Yeah, again, thank you very much. I mean, this was a incredible opportunity to present this paper. And please, if you have, I can understand that this could be, also difficult for some people to understand, but please, if you want, just let's get in touch. You can email me asking the very weird questions about mice, or I don't know, whatever you want, and I'll be happy to answer. Um, Thank you very much for being here, and I hope that there will be other opportunity like this, but also to build another review article with other people.
I could
Yeah.
just say that seeing your presentation, Biagio, even though I'm in this field, just makes me so excited about all the advances. I couldn't have dreamed there would be a presentation like this, 10 years ago. It's so satisfying to see all the questions and the needs we raise start to get answered. So, yeah, gives us a lot of hope.
Thanks.
This is Thank you both so much. I love it. Sarah Healy's kids have just put on their Christmas wish list a mouse model. So that's great.
They've been very good this
They've
year.
been they've been so good, Santa. Yes. No, I'm so grateful to all of you. Oh, I just want to make sure. Okay, yeah. I'm so grateful to everyone for showing up, for participating, for caring, and asking your questions. It really does. All of your participation means so much to us. Um, I have here at the bottom the link to our giving page for the end of the year. but I'm actually going to put in the chat the link to our annual report, just because I think it is a really wonderful place to look and see um, how much this community really is from all different angles coming together to advance our mission. And so I hope you have a chance to look. Thank you so much, Biagio, for going over all of this and being patient with me as we plan. I definitely will take you up on asking those questions. Thank you to Allison for agreeing to help moderate with these questions. So valuable to have your time and expertise. And I do hope you'll reach out either through info@ or directly to me if you have questions or comments or ideas. And that, I think, wraps us up.
Thank you very much. Bye. Have a happy Christmas
Thanks.
then.
Be well, everyone.
Yes,
Bye.
happy holidays.